Well, having multidisciplinary teams is key, and major cancer centers do this. We have disease management teams for all subspecialty cancers, including esophagogastric cancers, hepatobiliary cancers, and typically these groups meet once or twice a month, and particular cases are presented, radiology, films are reviewed, pathology is reviewed, endoscopic staging is reviewed, and we come to a consensus about what the optimal management is.
Multidisciplinary care works in two ways. There's a multidisciplinary clinic where we actually see patients with the surgical oncologist, medical oncologist, and radiation oncologist all in one center, under one roof, in a patient room all together. And then there is the tumor board setting, where patients are presented prospectively. The way we structure it at our institution is the pathologist generates a list of patients who've undergone biopsies or surgery over the last few weeks. That list is then given to the tumor board head, which includes me and some of my colleagues from gastroenterology. We review that list. As long as we understand we have all the patient data to prospectively make decisions, those patients are then presented at the tumor board. The tumor board essentially includes medical oncologists, surgical oncologists, radiation doctors, radiologists, pathologists, as well as support staff, which includes the genetic counselors, nutritionists, social workers, child life support team. All of these team members work together to discuss the case as they're presented at the tumor board, come up with a comprehensive plan. We tend to have a lot of debate when it comes to neoadjuvant, so it's a pretty lively discussion. And eventually, that plan is then taken back by the treating physician, whether it's a surgical or the medical oncologist up front, to then discuss with the patient. We have these meetings almost 3 times a week, so essentially all our patients are prospectively managed. But the strength in our institution also includes having the multidisciplinary clinic or the office hours, wherein these patients are seen every week in a timely fashion, so that there's really no delay of waiting for the tumor board to then present these cases.
Esophageal and gastric cancer are relatively uncommon in the United States, and because treatment of these diseases involves participation with the radiation, medical and surgical oncologist, as well as the gastroenterologist, you really need a skilled multidisciplinary team that interacts, reviews cases, comes to a consensus about management. We also know, certainly for esophagus and GE junction cancers, that the quality of surgery, even in gastric cancer, the quality of surgery is very important. And high volume centers tend to do better surgery, they have better outcomes, they have better supportive measures. So although there are good community-based surgeons, sometimes they don't see these patients that often. We really consider in these rarer cancers referral to a tertiary cancer center where there's access to a multidisciplinary team. The cases are discussed, consensus is developed, and patients receive the appropriate chemotherapy, potentially radiation, and appropriate standard of care surgery.
In our institution, what we strive to do is get the experts involved up front at the tumor board of the multidisciplinary clinic. And the way it works is that upper GI surgeons are designated specialists doing mostly upper GI surgery, and medical oncologists who have subspecialty, such as me, who does GI medical oncology. And we team up and discuss patients in both the forum of the tumor board on a day-to-day basis, as well as in our dedicated multidisciplinary clinic hours. That essentially leads to a very comprehensive, concrete plan for the patients and high level of expertise. We do have clinical trials open at our institution, but if there are trials available that the patient would benefit and would be good candidates, I essentially refer them out to those institutions. In summary, patients who have a specific rare diagnosis, if they're not seen in a community center or in a hospital center which doesn't have that expertise, then those patients should be referred. But in centers such as ours, where I believe we do have the expertise, I think those patients can be taken care of as they would in any other institution.